All right, so good morning, everyone. By interest of time, we're going to start. So it's a real pleasure to be with you this morning, and I want to thank first my co-panelist and speaker, Rahul Sharma, Morton Kern. Morton, you can come with us. I'm going to feel less lonely.
More space up here.
Yeah. I want to make sure that it will be interactive. If you have questions, please feel free to ask them. It's a very intimate session, and I want to thank OpSens Medical for doing this. A very exciting new technology here, and we're going to discuss some of them. So let's start. So we're going to talk about the future is sensor guided, and I think OpSens live up to the expectation with his optical sensor. So the presenters, myself, I work at Morristown Medical Center in New Jersey, Rahul Sharma from Stanford, and Morton Kern from Long Beach Healthcare System. So we're going to talk first. I'm going to give a little overview of OpSens Medical, the two products they have in the medical space, because OpSens is also another field with their sensor. Then Rahul will talk about the new kid on the block, the SCAI wire, that we can use for TAVR and other procedure. And we're going to close with the Morton Kern is going to talk about innovation in physiology. And we're up for discussion and question. So before we start, OpSens is a sensor. So they have a Fidela sensor, which is optic, fiber optics. And there's a lot of advantages over electrical or piezoelectric sensors. So the world is going fiber optics, so the electric connection are kind of going down, and that's true for telecom, aerospace, and now medical space. So there's a lot of advantages to have fiber optic sensor. One of them is accuracy and stability in the signal and the recording. So all those are true, not only for medical field, but for other fields such as telecom, aerospace, etc. So to give you a little bit of overview of OpSens as a whole, so yes, OpSens is known for their FFR or the DPR wires, so in coronary to assess physiology, but more importantly, OpSens is the sensor for years that has been included in the Abiomed machine. So all the implant we put, there's a sensor, and this is a sensor of OpSens. So the reason why I say that is very important because those sensors have been built to last for more than 90 days in the patient and to get accurate recording. There's Impella 5.0 that actually, or 5.5 that have been implanted for a year almost. So those sensors are built to stay and last in patient. So imagine if you do an FFR, that's for sure you don't have drift because this lasts for 1 minute. So, but those sensors are implanted in the patient for more than for days and months and almost years. So, and also OpSens Wire has a big division in neurology where they have a temperature sensor and also have other division in the gas and oil sensor. So very active in the optical sensor business. Their SCAI wire actually have more than 1,000 implants so far, so that's great. And there's more than 200,000 wire used in terms of FFR. So a very diverse portfolio. So why, basically, why OpSens with the Opto 3 wire is so good? Well, because in the middle there's one fiber optic, okay, and this wire is very good. It's almost like a work wire. It's made from nitinol and stainless steel. I'm going to go show you in the other slide. It's made of nitinol, very stable and very easy to use. It's feel like almost like a Pro Water or a standard wire. I use it when I do FFR. I use it primarily, and I can assess the vessel, do PCI, remove, and then do another vessel. So it's very, very solid and robust. Again, the optical signal, and when under the accuracy bucket, this is a core technology, and the lead engineer of OpSens is very brilliant, and this is what distinguishes from all the other wire. It's very stable and accurate, and this is very their brainchild. And then it just feel like a regular workhorse wire, and one of the key aspects is there's no drift, and we're going to talk about that. So in summary, this second generation fiber optic technology is very accurate, optical sensor, very stable and no drift. There's a technology where it compensates for the the temperature, the blood, etc. So very, very accurate, very robust. It's very kink resistant. And actually, because it's fiber optic, it's not vulnerable to any electrical interference in the room. And this is on the left what is the OpSens wire look like. You see in the middle, this is the fiber optic. And if you compare on the right on the piezoelectric, this is where there's 3 electric wire. So that's the reason why those wire, the piezoelectric wire is so stiff. It's because there's 3 electric wire and a stainless steel core in the middle. So it's not built as a regular wire compared to the OpSens wire, which is really fiber optic in the middle, large nitinol core around, and a stainless steel spiral cut around also. So this concentric design gives really a good feel to the wire compared to the other piezoelectric pressure guide wires such as Abbott and Philips. One of the key points with OpSens is there's no drift. And again, I said about Impella that they're very dependent on OpSens for their business. Why? Because they need the pressure to be accurate for days, for months. Well, this is the same when we do an FFR and we do a TAVR. We need accuracy, and we know that a drift of 2 millimeter mercury is very important when we assess serial lesion, when we assess significance of lesion. So it's very important and it's matter, and I think this is the reason why OpSens is so good. And this is Nico Pill's video, and you can see here there's no, it's very robust to any blood clot, change in temperature. You can see here he did a little bit of experiment when he's disconnecting the wire, going to put some blood clot in the sensor housing, and you're going to see that the reading is still as good as it was. So the key here is you can connect, disconnect, and you don't have to re-zero. It's very, very stable. So when we do a PCI and you put some balloon, some stent, and you disconnect the wire, and then after 10, 15 minutes, you reconnect. You don't need to re-zero. So it's very, very accurate, and then you can move to the other vessel. You're going to see the measurement didn't change, even after blood and everything. So it's still 1. Okay. So and same thing here is very kink resistant. Even if you kink, there's no change. So it's very, I would say, the best technology out there in terms of fiber optic, in terms of wire constitution. You can see here no difference. So I think for me it's big volume about how good it is. Now the new kid on the block actually is a TAVI wire. So they use the same sensor that they have in an Abiomed machine or in the Opto 3 wire, and they put it in a dedicated TAVR wire. So the wire actually is very unique, O35, good stiffness. Second component there, they put a sensor for the pressure on it, so you can have a live gradient. You connect and disconnect the same way you do with FFR. And on top of this, you can pace on the wire. So this is FDA approved. This is the only dedicated wire for pacing in the LV pacing, and the only dedicated wire for TAVR to have a continuous gradient during your case, before and after. And Rahul will show you a little bit the value of this. So this is the beast. So 0.35 guide wire, 280 length, spray shape, similar to a Safari, and is a very nice color, orange, so you cannot miss it on the table. And there's a PTFE sleeve to insulate for make sure that the threshold of pacing is great. And again, there's the same Fidela sensor, optical sensor in the LV. And there's an optical connector with the same accuracy as the FFR. So this is some cases. I've been using the wire for at least, I think, more than 200 cases so far. We use it with Evolute. We use it with the 26 or 29 to 34. Even if we're more a Sapien center, we still do some of the Evolute and very good behavior, especially for the 34. So the 34 has a tendency to jump a lot. So it's very stable in Evolute case. And this is a typical case, one access for the groin, one access for the pigtail, no pacing, very good behavior when you cross the arch. And this is the LV pacing and the valve deployment. And you can see very, very stable. And after 5 or 10 cases, you really get the concept of LV pacing, where you stabilize the system with your left or right hands, and you really have full control. And when I test the wire, usually I don't test the wire, but when I test the wire for the threshold, it's always around 2 or 3. So we crank up the output at 20, and there's no problem. In 200 case, we didn't have any issue with embolization or loss of capture. So I think it's really probably the future of TAVR, and then we have the gradient. And we know if you have to post dilate or not. This is just speak about how versatile the wire is. This is a case was done in Montreal Heart. We don't do a lot of axillary anymore. We do other approach, but you see the tortuosity. They were able to navigate to an axillary, a tough axillary case, very tight vessel, and deploy the valve and be very successful. And you see actually what you have on your screen. You have the gradient pre, the gradient post, and you can export that to the chart. And this is what we did is we did a complementary study. There was a first-in-human study done with perfect result. So what we did, we took 20 patients at Morristown where we used the wire and the software of the SAVI wire, and we compared to 2 pigtails. So the gold standard is the 2 pigtail, and we compared to the SAVI wire, which is only the wire, and we have very, very good accuracy. We can see here, OpSens wire, SAVI wire compare to 2 pigtail, perfect correlation. So very important. There was no big variability between pre and post gradient. So for me, it's become the new gold standard instead of taking a 2 pigtail. This is the interface that you have when you do your implant. You can have the systolic and the diastolic pressure, or the LV and the AO. And you can see also soon you're going to have new indices. So for aortic regurgitation, the RE index, and other index that's going to give you an idea of what is the aortic regurgitation. So when I use it for TAVR, it's great to see the gradient before, the gradient during, and the gradient after, and then you know if you have to post-dilate or not. I use it a lot also for balloon valvuloplasty. You just need this wire, you pre-dilate, you post-dilate, and you know if you're done. So it's just remove a lot of annoyance, no more venous stick, and it's kind of improve the flow of work. So I'm going to stop on this overview. So first, the SAVI wire is good property characteristic in terms of body and stiffness. It's spray shape, similar to a Safari. The hemodynamic are great, so you know what you're doing during the case, and you can pace on it, so it kind of is 3-in-1 value proposition. So I'm going to stop there, and then I'm going to invite Rahul actually to discuss a little bit more in detail the SAVI wire, and maybe after that we can discuss and have questions. So thank you so much. Rahul?
And I actually should give all credit to Philippe for the fact that I use a SAVI wire. He said you should use this, it's a great wire, and if there's one thing I've learned is always listen to Philippe when it comes to new technology, and read Mort's book to be like Mort in the cath lab. So 2 very valuable people up here with me today. So I'm going to do a little bit of a deeper dive into the SAVI wire to facilitate lifetime management, the idea of TAVI durability and clinical outcomes. These are my disclosures. Most obviously, I'm a consultant for OpSens. So some of this Philippe already covered. We're going to do a little bit of a deeper dive. So, you know, my standard practice prior to using the SAVI wire was to have a separate venous access like most people do, float a balloon temporary wire, use that for the temporary pacing to deploy a valve, and then to measure gradients, have 2 pigtails, as Philippe alluded to, which is, I think, what probably 90% of people do. And I think the big change for me was obviously the efficiency, and I always tell my fellows with efficiency comes safety. So it's 1 less venous access site stick, which means 1 less potential site for vascular complications. We always think about the large bore vessel access as a site of vessel complications, but I've seen plenty of venous oozes that cause morbidity, less rarely mortality, but certainly morbidity for patients. So that was off the table. The other issue is that when you're using any type of pacemaker, the issue of capture and stability becomes a big one as well. And you know, I've got plenty of cases on my laptop showing embolized valves because of loss of capture at the most inopportune moments, despite checking adequate thresholds on these balloon tip pacemakers. They can migrate, they can move. I wasn't so keen to use an active fixation lead for a short period of time. The idea of 2 pigtails to measure hemodynamics, obviously you have a second pigtail arterial access site, having to flush those all the time, re-zero constantly. I'm not sure how many people use Expert, but that's a constant nightmare. When you look at it and you think that gradient doesn't make sense given the deployment, and sure enough, you reflush everything, re-zero everything, and it's an internal error. So all of those elements taken off the table, and so it really added an element of efficiency, but also safety to the procedure. So the idea of continuous hemodynamic measurement is really important. So we'll show you the workflow of how this actually looks in the procedure. But you can see here on the screen, you have your aortic transducer with your mean systolic and diastolic pressures. You've got your continuous left ventricular end diastolic pressure there through the SAVI wire, and then the gradient. Now, I will say that with the more recent iterations of the software, the automation, the detection of both of these pressures simultaneously has become better. There's no real delay between the aortic and LV pressure. Philippe mentioned using this not just for TAVR, but also for balloon aortic valvuloplasty. So it's very useful, minimizing all of those exchanges. This wire is, I think, somewhere between a Safari and a Confida in terms of stiffness, so it provides a robust rail on which to deliver the TAVR platforms, or a balloon platform, obviously, for that matter, but also providing the flexibility and the pre-shaped curvature to sit safely in the left ventricle, but also importantly to maintain that position so that you don't lose capture. It's very important to remember that that pacing element is within that coil of the wire. So this is what it looks like schematically. You have your standard pigtail in the aortic root to take your aortogram for coplanar view, and also, of course, to measure your aortic pressure. The wire sits across the valve there. That pre-shaped curve sits nicely at the apex. I will say that the best way to deliver this safely is once you've crossed the valve is to use a pigtail to exchange it to ensure that you're not caught up in any chordae or up in the mitral valve, and you're safely in the apex, free in the cavity. And then you can see that orange dot there is representative of the pressure sensor. So this is measuring the left ventricular pressure simultaneously as the aortic pressure, and you can see there on the screen you have a gradient between the two. Another important feature is this idea of aortic regurgitation index. So importantly, when we measure gradients afterwards, we're obviously looking for any residual gradient, but we're also looking for any significant PVL. As we move to a more efficient system in the lab, a lot of people have moved away from TE. We're now using conscious sedation. Some people are doing an aortogram to check for any residual PVL or central leak. And a lot of people have even moved away from doing any echo in the lab, and they just get an echo once they return to the room. I think it's really helpful if you're trying to build an efficient program and remove some of these extra steps to have an element like this where you have a more robust measure based on physiology of the significant aortic regurgitation that may be there, either to warrant post-dilatation or further assessment to see what the cause of that significant aortic regurgitation index is. So it's important that the wire positioning in the valve is done in a fastidious manner for a number of reasons. One, obviously, to safely deliver the valve. That's just the standard application across all TAVR delivery wires. But importantly, you want to make sure that the wire is not pinning open, causing aortic regurgitation, but also that that sensor is located in an appropriate place. And you want the wire to be in a stable position so you're not causing too much ectopy and affecting the different transduced gradients. You want to make sure that you flush the line like you would with any line. The coating on this wire is a little bit more granular. It's not as smooth or hydrophilic, and so you want to make sure it's adequately flushed so no clots develop. The LV pacing, I will say the biggest thing I noticed about this was the stability of the pacing. I was a late convert to LV pacing. I went straight from RV balloon tip wire pacing to the SAVI wire. There was no intermediate for me. So I was a late adopter. It's not usually what I would associate myself with, but I certainly was to this game. And I was really remarkably impressed by the stability of this. The ability to not worry about the fact that I might lose capture. The wire is very stable. You can really see and look for the squeeze of the left ventricle on that circular portion of the wire. It's important to obviously ground this. You're trying to create a continuous loop between the anode and the cathode. There are many ways to do this. This is the way we do it in our lab. We just use the micropuncture needle or an IV needle that we'd use for access through the skin adjacent to the contralateral site, and then we clip one of the alligator clips to that end. It doesn't matter which color goes where, it's just a continuous loop, so that's the grounding element. And then the other end goes to the back of the wire. You can see there on the left. In this case, the black is to the exposed part of the back end of the wire, and then the grounding is the red to the skin near the groin. And that creates that continuous closed loop to deliver the current. So basically, you want to make sure that the guide wire is in contact with the LV. That's how you're going to actually disseminate that current to create LV pacing. I mentioned you want that grounding anode, and you make sure you penetrate the subcutaneous tissue, and then the cathode attached to the guide wire. It's important to make sure that that cathode that's attached to the guide wire is actually attached to the metallic part, not to the coated part. And sometimes it's very difficult to see, so whoever's on the back end needs to make sure that's correct. And then you just test the thresholds. Again, we're not trying to implant a permanent pacemaker. You test at a maximum threshold, walk it down quite quickly, and I usually, once it gets to 10 and we're still capturing, turn it back up to 25 as the max output, and off you go. So depending on what you're trying to do, what your goal is, obviously your rates are different as it would be for any clinical standard situation. Higher rates for a balloon expandable valve, perhaps lower rates for a self-expanding valve. and for a balloon aortic valvuloplasty. It's asynchronous mode pacing, as you would with any temporary pacing, so that's very similar across the board. So again, the workflow is you check your pacing. You can check it either once your valve's in or beforehand. Again, I like to minimize my steps, so I do it once the valve's in. But once you've done cross your valve, got your gradients, you can then disconnect the transducer on the back, similar to an FFR pressure wire transducer, load your valve on, advance your valve, clip your alligator clip on, check your pacing thresholds, and then go ahead, advance your valve, and deploy in the standard manner. Take the valve out, connect your pressure sensor back onto the back, and measure your post gradients. It's a really, really efficient, seamless workflow. I brought this into a second satellite site now of Stanford in the Bay Area, and it's remarkable, even this relatively lower volume satellite site, so immediately impressed with the efficiency of this workflow. I'm not going to go into too much depth here, but this is just one of the studies of the LV pacing data. The basic message is that it's safe, it's effective, and it's efficient. You can see there reduced fluoro time, and actually, quite interestingly, cost becomes an issue. A lot of people ask, how much is this wire? And they kind of balk at the initial price. There are much more detailed health economics analyses of these, and I certainly looked at those because it's important. When you're working at any facility, but particularly a tertiary academic facility, the bean counters look very closely at new technologies, especially those that have a high sticker price. But what's important to remember is by the time you look at the efficiency of the procedure, the time saved, remembering that cath lab time is arguably the most expensive time in the hospital, when you look at any complications that may ensue and the costs associated with those, even if those complications are rare, such as RV perfs from pacing wire, very quickly this becomes a cost-effective and efficient procedure. This is just another study from Erasmus, again looking at the rates of new left bundle branch block, new pacemaker, length of stay, rehospitalization, neurological events. There's some interesting observations there. I wouldn't read too much into this. The study was not powered in terms of these clinical outcomes and endpoints specifically, but the main message again, that there are no adverse outcomes associated with this. It's certainly efficient and at least as good, if not better, than current standard of care. The first in human study that was done, 20 patients, severe asymptomatic AS. Here, again, no complications related to the guide wire as one would expect. There's less steps, there's less exchanges, so it should be safer. You can see here, no deaths, no strokes, one major vascular complication, no rapid pacing capture failure, which is important. At least once a week with the number of TAVIs that we do, and I'm sure Philippe and at Mort's lab they do, you at least will get one loss of capture. Fortunately, it doesn't always result in embolization of the valve, but it means starting again, repositioning the wire, rechecking the thresholds. So this is just, again, I think Philippe showed this slide. This is just, again, to hit on the versatility of this. This is not just for a balloon expandable platform. You can use this across any platform successfully at those different pacing rates. It's important to make sure that the wire, again, is positioned at the apex. In fact, you want to see that apex squeezing down on the wire because that ensures you've got adequate contact to make sure that your pacing is successful. And you can see here the wire's safely positioned. Looks a lot actually like a Safari Extra Small in terms of the curve. But again, as I said, it has that stiffness that's somewhere between a Safari and a Confida wire. And again, very stable. And to date, I've had no issues with a loss of capture or anything like that. Very, very stable procedure. Once you've deployed your valve, this is the second part of the workflow. So where previously you would then exchange your workhorse wire, your Amplats or your Safari or your Confida for a pigtail, flush it, reconnect it, and remeasure gradients, none of that happens anymore. You simply pull the wire back. Remember that dot which represented the transducer? Now you want to pull that back as close to the valve without coming out so that you equalize with your aortic pressure. Once you've equalized on the same system, you simply advance the wire gently forward back into the LV once you've calibrated to get the differential gradient, residual gradient between your aorta and your LV. So again, very simple, very quick. You're not interrupting the workflow at all. Less exchanges, less flushes, safer. So in summary, you're reducing the devices overall. You're replacing your traditional TAVI guide wire. You're replacing at least one transducer. There's no need for the venous access kit, no need for the RV pacing wire, and no need for a closure device if you're using one for that venous access site. That in turn, of course, supports the case efficiency. You've reduced your transducer setup time from the lab staff. You've eliminated the need for venous access and device exchanges, which is helpful for all of us, particularly when you're training fellows and residents. You're standing around waiting. It feels like an eternity in the lab. Minimizes exchanges for the pressure readings. And then finally, perhaps most importantly, you're enhancing the procedural predictability, which is ultimately what we're trying to do. We're trying to get the best and safest clinical outcomes for our patients. And that continuous accurate measurement and display of the hemodynamic pressures constantly really helps with achieving that, as well as minimizing the RV pacing complications. Thank you so much.
So we're going to talk about resting hyperemic ratios a little bit. I did want to cover some of the innovation in the wire again, but I won't spend too much time on it. Here are my disclosures. And I mean, I think the field of coronary physiology and assessment of coronary lesions has exploded in the last 10 years, certainly. And if you just look at this number of ways in which you can assess coronary artery disease and manage things, you have a whole list on the far left of non-invasive methods. So, of course, echo stress, MRI, PET scanning is now very useful. Invasive methods have also expanded. Beside the FFR, you have resting ratios. That's on the bottom middle panel. There will be coming Doppler flow. Again, there is thermodilution flow, which is the far right middle panel. You have IVUS and its potential to generate an image stack of physiology data as well, which is coming. OCT, not on this list, can also be used to derive physiology. And then you have the FFRCT on the bottom right, which is a fantastic tool. Before you come to the cath lab, you get your coronary artery disease known, and you get your physiology with it in a manner superior to most stress testing. That is, the correlation to a measured invasive FFR ischemic number is better with FFRCT than perfusion imaging, stress echo, or your other stress method. So we have entered into a new era, and I don't have to convince anybody that I think physiology should be part of routine coronary interventions. And both imaging and physiology are required and should be part of your current practice. I'm not going to ask anybody who's not using it. Put your hand down. No, not. So we're not going to do that, but it's really highly valuable. Okay, so the non-hyperemic or resting ratios have entered the field in 2012 by Justin Davies, bringing in this number called the instantaneous wave-free ratio. And I was at a session yesterday, and somebody said, okay, so how do you define the instantaneous wave-free ratio? How do you define it? Yes. Exactly. So what does wave-free mean? Anybody know? I'm sure you do. Tell me. The wave-free period is the period, you're right, but the wave-free period is a little more. So when the heart beats, boom, it sends out a pulse. The pulse is reflected back. There's a reflected wave, positive wave expanding, a negative wave contracting, and these waves move until the heart stops acting. And that's diastole. And then during diastole, there's a certain point after the closure of the aortic valve in which there is no more reflection. That's the wave-free period. Then the pressure and flow move together because resistance is constant. And so at that point, Justin Davies said, well, that must be the same as FFR. And he took that ratio. You can see on the left the WFP, the wave-free period, 25% of the way into diastole and 5 milliseconds before systole. And in that, they did this derivation. They gave it the name wave-free period. Since that development, everything in diastole, from the notch to the systolic ejection, can be labeled. And on the right, there are several other derivations of this diastolic ratios. And so you have the diastolic pressure ratio, the diastolic flow ratio, the DFR, the DPR by OpSens, DFR. You have, of course, always the mean PDPA. Then you have the relative flow ratio, the RFR, which is the lowest of the mean filtered, and a number of machinations around that. But the good news is all the resting ratios, with the exception of PDPA, are matched in terms of their clinical outcomes and in terms of the threshold number used for ischemia. 0.89 was considered the threshold. I do want to remind us that we don't function on a binary technique with patient care. So if it's 0.90, 0.88, everything has to match the clinical need. But the DPR is now available with the OpSens wire. So I'm going to show you that in just a second. Here are the thresholds, 0.89 for all but PDPA. If you don't like the number, let's say you're working in the border zone, you could then give a contrast bolus and get to a hyperemic FFR. That's called contrast FFR. And if your number is below 0.83, that's a high correlation with FFR, and you wouldn't have to go further. If you don't like that, let's say you hit another border zone number and you say, I need my FFR, .80 is the number people have been using. And again, the threshold of the gray zone has expanded around that because the error of each method has some value, you know, 0.03, 0.02 if you did repeated numbers. But these are tools that are far superior to just using angiography alone for decision making in terms of treat or no treat. So the innovations with nitinol fiber optic pressure wires, first coming from OpSens, I've known them for a decade now, are substantial, and I don't know, has anybody not heard of the OpSens wire before you came to this breakfast? Anybody? No? That's a great feeling. So you know about this. So qualities to address problems of the physiology world are those that address drift. And the fiber optic sensors are much more stable. Even within the fiber optic family, there are several that are better, and I think the OpSens wire meets that need. Automatic zeroing, plug and play, signal stability, that is a wonderful thing to have if you've encountered drift with your other wires. The resting ratios have the single advantage of not needing adenosine. There is no other advantage. People are going to talk about pullback, they're going to talk about everything else, but the reason they were developed is so some guy doesn't have to give adenosine. It was torture, I know it, but really it was very short-lived and not very painful. So anyway, you now have resting ratios. Pressure wires had a bad rap in the early days because they didn't handle very well. They were weak, you didn't like them, you had trouble steering them. All that's gone. The nitinol wire is a workhorse wire, and it provides something you don't have usually, which is a post-procedure wire. If you worked on it at the beginning, you have it at the end. You don't have to open a new wire. I think if the information of post-procedure documentation that you've really done a good job on pullback is important, this is a wire that you can use. And we'll talk a little bit about pressure pullbacks. A single FFR point in a vessel only gives you half the information you need, unfortunately. If it's normal, that's good. If it's borderline or abnormal, you need to know where that abnormality is to make a decision whether you need to go forward or whether you're going to leave the patient with some residual potential ischemia. So I think this pullback issue coupled to a single point post-PCI FFR is very important. And then in complex anatomy, these wires work. You can assess multiple lesions before you start, assess the lesion during your procedure if you like that. You can see collaterals, collateral pressure, and at the end you'll know what you've done and whether you need to do some more. It does not replace imaging for stent implantation. Nobody should confuse these two things. You can have a normal FFR and you can still have a suboptimally deployed stent, right? Everybody knows this? So imaging has its role, physiology has its role, and they're both part of the game. I think Philippe told you the differences between these wires. Here are the three categories. Now, the piezoelectric wires on the left have the three wires. They have a sensor. It had some problems early. They're much better now. The middle panel was the assist fiber optic microcatheter. It was developed so that you could use your own wire, which you liked a lot, and then have a pressure sensor delivered over it, and you can get your information at the cost of a slightly increased cross-sectional diameter. It's not a bad thing. It's just not necessary as much anymore because your wires on the right, your optical fiber wires, your nitinol wires, are very good handling wires. Signal stability is better, same thing. And on the bottom of the sensor generations there across, and you saw the little diagram how the diaphragms work. The technical aspects of these optical sensors is much better and much more stable than piezo wires. Now, the handling of the wires was always an issue. How do you prove better handling, right? You put it in your hands. You say, tell me how it feels. How do you like it? Oh, it feels great. How do you like it? Yeah, so they fixed this fixture of a tortuous artery, and they pass these wires through there. Now, I want you to look at those moving circles very closely. Keep looking at those circles. Look at the circles, okay? By OpSens, by OpSens. Oh, anyway, so you can see the eccentric wires move differently than a concentric wire, and that's probably the biggest aspect of better handling. All right, connections were a problem in piezo wires. If you got a drop of saline on that connector, your signal would be off. You might lose signal. You have to wipe. If you get moisture in the connector, you need a whole new system. Optical fibers do not have that problem. They see through the blood, through the saline. When they connect, they connect. And they're very stable. You can disconnect and reconnect many times. You can even bend the connector period because the point of connection is at the end. And with the piezo wires, a bend in the end of the wire can end that wire's life. Anyway, this is another advantage. I thought I'd just share it with you as innovation, and it is. And of course, this plug-and-play system gives you these features that we talked about before. And the display is pretty easy to use and see. It's right there at the bedside. Some people like to play with it themselves, and you put a drape on it. Others can set it and let your technical staff work it. You get your DPR, and you can get a DPR pullback. And then the newer software with the SCAI system can be on there as well. The three most common errors of PCI physiology are drift, not taking the FFR at the right time if you're using IV adenosine or bolus adenosine, and the catheter damping. These are three common errors. They happen all the time. We'd like to reduce them, and the one that you can reduce the most with an optical wire is drift. This was again demonstrated earlier. When you compare these from the data provided to us, you can see that the optical sensor wire from OpSens was superior with lesser drift. I like that. Now, is there zero drift? No, there is never 100% zero drift, but 90% of your cases or more will have no drift, and 7.6% in this study would have a little drift. But you have much more drift with the other wires. So this has an impact. I know we talk about drift. Well, why does drift matter? In resting ratios, it could add as much as a 20% error compared to a hyperemic ratio of FFR. So here are the impact of a 2 millimeter drift on PDPA on the bottom right, IFR, and then FFR, right? And so if you generate a 30 millimeter hyperemic gradient, if you're off by a couple of millimeters, you'll still get the same number. In the resting ratio, when the difference may only be 10 and you're off by 2, that's a 20% difference. So drift is important, and the good news is we can minimize drift with this wire. I've been happy with it, and I think this is an important concept to take home. Okay, now I wanted to bring the pullback, which I didn't, but I brought one pullback right here. So I think the biggest innovation we've seen lately in the physiology world is this post-PCI or pre-PCI pullback assessment of the mix of focal and diffuse disease, which is always present in coronary artery disease. And the controversies in the hyperemic and resting ratios are sort of exaggerated in these pullback tracings, that is, you can see information more. So this concept that in focal lesions, the turbulence across a focal lesion leads to a more positive FFR when you might have a negative resting ratio. That is, the turbulence doesn't affect the resting ratio as much as the hyperemic ratio. So disparities occur with a positive FFR, negative resting ratio, negative DPR in focal lesions, and the reverse is true in diffuse lesions. So in diffuse lesions, the frictional coefficient leads to a negative FFR, but a positive IFR more of the time. And so that's really the differentiation. So where do I want to use the hyperemic ratio? Well, you may say, I want to use it in the focal lesion more. I might get a better correlation. Or if I have more diffuse disease, I want to use the resting ratio more. Now, this doesn't help you make a decision up front because you don't know this yet. So does it matter if you use FFR or resting ratio to get the answer to your question? Does that lesion need treatment? And the answer right now is no. You can use either one. And the data says that the resting ratios are non-inferior to hyperemic ratios. Excellent. You're going to see data coming out of the PCR that suggests, well, maybe long-term there might be a little more events with the resting ratios, but we're not there yet. So just to clarify, low EF, coronary bridges, aortic stenosis, diabetic diffuse disease, refractory. That's the right side of the panel, and you can assess this with pullback easily. You will identify focal lesions during that pullback, and the focal lesions are often in those at large territory, proximal, and post-PCI. You want to see that focality of what you've done. You've cleaned up a segment of the artery by stenting, but what about that little area beyond it, around the curve, or proximal that you didn't suspect. You will know that with your pressure pullback. Okay, I think I'm going to run out of time, but so what I'm showing you here are two graphs of PCI according to the phenotype of disease. Do you have diffuse disease plus focal, or do you have predominantly focal disease? The way we detect that is with a pressure pullback gradient, and we detect those combinations of patients who have that focal and diffuse disease. If you have diffuse disease, no matter what your gradient at the end of the procedure is, that's this red case, the left Kaplan-Meier graph, the red is the diffuse disease without gradients. And so you have events due to this burden of coronary artery disease, and you can't get around it. And if you break it up on the right side, the two yellow and red curves there on the right side are, again, those patients with diffuse disease, one with gradient, one without gradient. And the bottom are focal lesions with and without gradients. And once you treat those, they do very well. So diffuse disease is the bad actor here. And if you want to know why your stent patient came back with a problem, it might be because he had diffuse disease and you were only able to address the focal aspect. I want to show you a case and then I'll stop. This was done not long ago with the OpSens wire. A 68-year-old man with hokum, dyspnea, prior stents, and he had no chest pain, but he was having a lot of dyspnea. We thought this was a hokum issue, and we're going to assess it. The LAD here, this is eleocaudal on the left and eleocranial on the right. And if you look at the proximal LAD, I don't know if you can see it in this light, but there's a large lucent area, probably calcific nodule, and it looks severe. Okay, so take another look. I think you would agree with me on the left, which is areocrani. You can see the LAD has a lesion, right? Everybody see it over here? Mm-hmm. You think it's significant? It looks significant to me. That was a bothersome image. And on the right, you can see in that areocaudal. So before I get too far involved, I want to know what's going on. Now, the right was interesting as well, tortuous, and then look at the bottom at the PDA. See those three little lucent areas down there? I'm not happy. I don't like this, right? Positive or negative? What do you think? Positive or negative? The right coronary artery. Going to be FFR positive? Both? Positive and negative? You said both positive. I would concur, and that's exactly what we looked at. Now, here's the hokum part of this, and it's more apical than mid, and so this guy at the moment did not have a gradient at this point in time. I would have liked to have the SAVI wire. This would have been perfect. I'm going to show you the case where we used a SAVI wire in just 1 second. Anyway, we put the FFR, we put the OpSens wire up. It works really well. It worked fine. I was surprised, delightfully, that the pressure gradient here was nil, and that the FFR, the DPR on the bottom was, this is resting, this is hyperemic on the bottom. It's FFR. So this was what I thought was negative. On the right coronary artery, same. We had a nice high DPR. I'm not going to get excited about 8-9 with that ugly looking lesion in an asymptomatic guy who's got dyspnea with this kind of LV. And then the FFR over here was a little more dramatic at 0.8. Again, I'm not getting excited, right? So what I am is happy that I don't have to work in this right coronary artery because this looks like a battle. Okay, so that was our multi-vessel. He had these lesions assessed a couple years ago, which I later learned was true, and they were still negative from a prior exam. So I'm happy about that. I want to show you a bonus case. This is a guy who had mild aortic stenosis by echo. He was here for coronary angiography, and we happened to have the SAVI wire in the lab that day for demonstration purposes, and we got to use it. Now, this was our old technique of measuring AS with a pressure wire. And so the pressure wires through a diagnostic catheter across the aortic valve, beautiful tracings. This is aortic stenosis. We didn't have software at that time, but you could use the coronary software. There's really no doubt this patient had critical AS. I'm going to show you the next guy where we use the SAVI wire, which is here. And we didn't have a recording system, so we just clipped it. So we matched up before we crossed. Oh, sorry. We crossed with the wire, brought the guide back, zeroed. Then I took it back out, and SAVI wire's in the LV, And here's the tracing. And I'm just going to show you. You can move the guide catheter just in and out, and in and out, because the wire never loses position, and so the guide just goes right over it. You're going to see the so mild aortic stenosis, anacrotic shoulders present, dicrotic notches present, and you pull it back, and it's perfect. And if I wanted to, and we did it several times, you just push the guide back in, your gradient's there, and you could assess certainly along the outflow tract gradient. See, I just pushed it back in, I got my aortic stenosis. Anyway, that was, I thought, a brilliant insight for me to understand you can use this wire for such good work. Okay, in conclusion, I think we're in a new era of innovative technology for physiology wires. I hope I was able to demonstrate some of that for you. Stable ischemic heart disease, bread and butter every day. You should be using physiology over angiography for decisions. Acute coronary syndromes, use it in the non-culprit, don't use it in the culprit. We can talk more about that if you want. For PCI, pullback to ensure that you've cleaned up all the areas that you need, or whether you're working with residual diffuse disease and you have to counsel your patients, you have disease, we're going to medically manage you, beware. And that's just the life of that. And then the microvascular disease field, at the moment, we have microvascular disease assessment with the Abbott wire systems because the core mica, or the core flow is there, but OpSens is developing its own coronary microvascular disease indices and assessment tools. So stay tuned for that. I think with that, I'm just going to stop and say, let's talk about it. What do you think? Thank you. Thanks very much.
So Morton, it was a beautiful talk. Thank you so much, as usual. So we have 2 minutes for question. I don't know if there's any question from the audience before we discuss.
Okay, good. I'm glad you asked. The 5-year defined data from the PCR said IFR had a higher mortality. I don't quite understand it exactly, because if it was a bad thing, it should have shown up earlier. So what does a lesion that is IFR negative today, 5 years from now, mean? So I think it means that the resting ratio probably missed a few lesions that progressed, or would have progressed based on a hyperemic assessment. And although the concept that if your resting ratio is normal, but your hyperemic ratio, the FFR, is abnormal, means that you do have high flow through that lesion, it doesn't mean it protects the lesion, and it doesn't mean the lesion's negative. So I confess from the very beginning I had to struggle with accepting resting ratios. That's why a lot of my studies are resting, contrast, FFR, and I get all my information. We do it mostly to demonstrate the physiology and collect data and understand it. But if I was in clinical practice, right now, I'd have to say I'm going to do FFR. But my colleagues in the non-hyperemic pressure ratio world don't like to hear that. But it's life. And, you know, if it had been the other way around, FFR, let's say FFR had the mortality association, it would, you know, we'd say the same thing. You know, how come 5 years later, all of a sudden something else? Yes, sir. Thank you for that good question, by the way.
For almost like past 15 years about the FFR and all that. When I look at the diastole, that flow ratios, wave-free ratios, if you look at the diastole, it has 4 stages, you know, isovolumetric relaxation, early rapid filling phase, diastasis, and then late rapid filling phase. But you got only the reading in that early rapid isovolumetric relaxation, and then, you know, kind of diastasis phase. That's where you calculate. I think of FFR, like what you taught us, I think more accurate than diastolic flow ratios. That's what I see majority of the times. I do both, and there is a conflict we discuss, and then, but ultimately, I try to do mostly FFR.
So
just to give you an idea.
Thank you very much. Let me just put something out there for you guys, which is going to disturb you. So if you think about IFR, it was validated against FFR, right? And FFR was validated against a series of stress tests. And what are stress tests validated against? What were stress tests? They were validated against the angiogram. So here we have come full circle now to say that the physiology tests the angiogram, when in fact the angiogram was used to validate the stress test, FFR, and so on. you don't have to worry about it. PET scanning at a certain value will give you the accurate ischemic thing. I think when you say one's more accurate than the other, it's hard to know what was the standard against which you were comparing, right? So ischemic testing is a challenge in every way in human beings, and so we have to take what we have. I think the data is much more robust with FFR because it's been around another decade before IFR showed up. I think the outcome studies say resting is non-inferior. That's all. It's not better. It's not worse. It's non-inferior. And now with 5-year outcome data, that just throws another big question mark. But I think you should use physiology. How you use it, I mean, which of the tools probably makes less difference than using it alone. Every study shows that physiology testing, resting or hyperemic, is better than angiographic guided approach, period. So the question was, does the pressure pullback co-register with the angiographic image? And the answer in the OpSens system, not yet. In the Philips system, yes. That's the only one I know, the other one. And it should be eventually always there. But right now, co-registration is a challenge for a lot of things, right? OCT has it, IVUS can have it, pressure can't have it. So it's kind of tricky. You have to step on the field and see where you are. It's not a loser, but it would be better if it would be co-registered. Good question.
So OpSens actually is working on it and actually would be available hopefully within 2 years.
Yeah.
But
It's coming.
Yep. So I think we are running over time, which is a testimony of how the session was great. Thank you so much, Rahul, and Morton was great, and thanks for coming
Thank
here.
you all.
Thank you for coming.
Nice job, Rahul. You're a giant. Philippe, another giant.
Thanks for your good thoughts.